So we'll start by just introducing everyone, and I'll maybe start at this end with Julia Sinclair. Do you want to introduce yourself, say a little bit about your background?
Thank you, John. Hello, I'm Julia Sinclair. I'm Professor of Addiction Psychiatry at the University of Southampton, and clinically I run the alcohol care team, as well as research and policy work.
And if we move down the table.
Thanks, John. Clive Henn, and I've worked in the alcohol field for over 35 years. Started off as a nurse, working with treatment and dependent clients, and then moving into public health. And in recent years, I was the lead for the public health programme for alcohol in PH at Public Health England.
Hi, I'm Alice Wiseman. I'm Director of Public Health in Gateshead and in Newcastle. I'm also Vice President for the Association of Directors of Public Health, and I have a special interest in alcohol harm.
Okay. And I'm John Holmes. I'm a Professor of Alcohol Policy at the University of Sheffield, and I've been working on alcohol policy for about 15 years, looking at areas such as alcohol pricing, drinking guidelines, and also trends in drinking as well. And we'll come to this end of the table now.
Morning, I'm Gautam Mehta. I'm a consultant hepatologist at Royal Free London and an associate professor at University College London. My main interest is alcohol-related liver disease. Done some clinical trials for interventions for these patients, as well as generating some observational data on risk for liver disease in particular.
Hi, I'm Rosanna O'Connor. I currently chair Collective Voice, which is the umbrella organisation representing third sector drug and alcohol treatment providers. Prior to that, I worked as the Director for Addictions in the Department of Health and Social Care, similar role in Public Health England, and was a Director in the National Treatment Agency for Substance Misuse prior to that.
Yes, I'm Peter Rice. I'm Chair of the Institute of Alcohol Studies, which is based in London. My trajectory is similar to Clive, starting off as a clinician, as a psychiatrist working in alcohol problems service in Tayside in the east coast of Scotland, always interested in prevention, and had the opportunity to do some work on that at Scottish level. And I work with, I suppose, a range of NGOs, a local one in Tayside and at Scotland, UK, and also do some international work through the European Alcohol Policy Alliance. And I've worked for the World Health Organization as well.
And then finally, Alni.
Hi, I'm Annie Begaita. So I'm a lived experience advocate. I do a lot of work with different organisations at policy level and also at grassroots level, working with members of the public, different communities, those hard to reach communities, but also getting involved with Royal College of Psychiatry. I've done work with various organisations.
So this first session is going to look at what are the problems that alcohol causes and what is driving those problems? Why do we see those problems? And we're going to explore that in a little bit more depth.
I think there's a variety of reasons, but I think one of the things is that it's abnormal to not drink still. It's still abnormal to not drink. When I say I don't want to, when I go out, obviously everyone's used to it now because I do, it's widely known that I've got, I'm a recovering alcoholic, but initially it's like, oh, why? Just have one. No, I'm an alcoholic. Then they're like, oh, yeah, we are too. No, really, I really am. So it's still abnormal to this day, even though it's on the decline. If you look on TV, there's alcohol everywhere, It's still seen as a trendy coffee bar is seen just as classy as a trendy wine bar. We'll meet up at the wine bar or someone holding a glass of wine. You see it everywhere on social media as well. It's still not seen as an addictive, dangerous substance. And it's very easy to hide your addiction. Even if you go out to a party, I always say, if I went to a party and I pulled out a bag of heroin, everyone would stop and look at me like, what on earth are you doing, Annie? I'd probably lose some friends straight away. But if I drank too much, oh, she's letting her hair down. It's very easy to hide. So that's one thing I will say. The other thing I will say is that although we're looking, there's a lot of work being done around looking at the harms of alcohol, but actually the majority of people who go down that line of addiction, there's trauma in their past. Well, there isn't a lot of trauma-informed support services embedded in local service frameworks. We're waiting to a point where someone's got to addiction and near death to give them that treatment when that person could have gone. I talk about that person myself. I went to a trauma-informed rehab when I was given 12 months to live. Whereas that trauma-informed therapy could have been given to me at that time when I disclosed all of this trauma, which probably, well, we don't know, but may not have led me to that point. But, I think the argument is, why did I have to nearly die to get to the help that I needed? And what about the other people who have gone down other lines of addiction? I come from a community that's hard to reach. Firstly, with that community, there's fear. There's fear around addressing the alcohol use within that community, just because of all the, barriers. The people are scared of PC, people are scared of offending people, they don't know how to approach it. So you've got a whole chunk of people that are not within the stats. The stats doesn't reflect those people. They will never reach out to services. Usually they're ostracized, they're cut off from family members, and that just leads them to, their addiction to become progressive. But as I said, they're hidden.
Perhaps, Julia, do you want to talk about some of the problems you experience or you see in your work?
It's people for whom they've been often drinking at very high levels for a very long time, and are now starting to show both the harms of alcohol in terms of the physical harms, which is what I see, as well as alcohol use disorder and alcohol dependence. So I think very much now within acute care and within our non-specialist services, this is where we are seeing patients present with all sorts of underlying problems, but which actually the alcohol is often driving those problems, or they're presenting with, in alcohol, significant alcohol withdrawal, which requires an inpatient admission, and there are no specialist services for them.
Yeah, and I guess often when people are presenting for treatment, they might be experiencing problems with addiction, but there's often a lot else going on. There's physical problems as well as those psychiatric problems.
Yes, and I think just to clarify, I think where we're seeing most of the problems within the health service now is not with people presenting for treatment. It's in people who are required to go into a general hospital or are going to see their GP. But the problem underlying that is their alcohol consumption or their alcohol dependence.
Yeah. And Gautam, I guess you see the other end of that as well. You see people come into your clinic with quite severe liver problems.
There's no doubt that the frequency of people coming in with liver-related harms is increasing year on year. The data are quite clear, but I see that in hospital and the wards every day. There's more patients year on year with complications of liver disease, serious liver failure, jaundice, those sorts of very serious life-threatening complications, leading to an increase in deaths. But it's not just the absolute numbers. We see probably more women, slightly more younger people, but overall there's anecdotally very clear reflection of what the data shows, that there's more patients year on year. This is a disease that affects people of working age, contributing to life, to family life, hopefully, and with many, many years of productive life still to live, hopefully. Most people don't know they have liver disease until they have a severe catastrophic complication. About 70% of people in hospital haven't had a previous incident, event, or a diagnosis of liver disease. Of those, a quarter will die within a matter of months. So there's a huge opportunity for preventing those acute complications, but of course it's a tragedy that this affects working people. It's the second commonest cause of preventable death in the UK at the moment, stunningly, without great therapies, whether those are genuine medical therapies for the disease, or of course all the other preventative work that we will probably come across today.
Yeah. And we've talked kind of so far about the kind of sharp end of these problems, and also the stuff that's very clearly attached to alcohol, liver disease, alcohol use disorders. But it's not just about that. A lot of the harm from alcohol is actually from conditions that have multiple causes or can be caused by a lot of different things. And I guess, Alice, you see quite a lot of that in your work as a Director of Public Health.
I almost see the opposite end of the iceberg, if you like, to the things that you see, because over half of the population that I work for, that I serve in Gateshead and Newcastle, are drinking in a way that's harmful to their health, and they may not end up in acute clinics, but they may end up in a breast cancer ward or, in a GP practice seeking medication for low level depression or anxiety. And I think part of that challenge is that those people don't often necessarily associate alcohol with the harm that they're experiencing, because what they think of is the problem is with those people who are addicted to alcohol, who are drinking every day. And actually the reality is that alcohol is much more harmful than that. So some of the challenge that we've got is, if we're going to talk about it from a public health perspective and a population perspective, that those sharp ends are really important, but it's actually really important that the public don't understand the harm that's being caused by the substance that is so normalised in our society. And actually what we need to do is help our populations to understand the harm that's caused at that much lower level. Otherwise, we're never going to be able to change this.
Clive, can you just take us through what some of the most effective alcohol policy options are?
Multiple systematic reviews, World Health Organization, OECD, Public Health England have interrogated the data and looked at what the evidence says. And there's a pretty universal sort of grouping of what they come up with. In terms of it's reducing affordability, and affordability in this country at the moment, I think it's 72% more affordable than it was in about 1987. So it's how you adjust price. And we know something about the mechanisms to do that. We know duty can be adjusted, so a tax on alcohol, and we've got a duty system now, which is based on strength. Minimum unit price, which they've got in Scotland and a number of other countries. Availability is, we know that if you reduce the hours and days of sale, you reduce the harm in the environment, especially if that's in the nighttime economy. It's difficult to do, but you know what I mean, we know that would have an effect. Marketing restrictions, so pulling back on the sort of heavy marketing. Treatment and sort of interventions for people who are beginning to become at risk, like brief interventions, have an effectiveness. On your point of what doesn't work on its own, and the one which is often pushed is public information. And that on its own, we don't have evidence that there's behaviour change behind that. But in conjunction with everything else, it could have a role.
People are actually more supportive of alcohol policy than you might think.
Yeah.
They do actually support, overall, increasing alcohol prices, restricting availability, restricting marketing. But the policy they like most of all is more information, more education. So why do they kind of like the more ineffective policy?
Well, I think there might be just a general feeling amongst the public that that's what works. Give people more information and they will change their behaviour. It's a sort of a rule of thumb which isn't borne out in the evidence.
I mean, I think this debate about information education is really helpful. I mean, one of the things that has become government policy in recent months is to introduce health warning labels on alcohol products. Now, they haven't said what they mean by a health warning label. I think that's still being developed. Do we expect those health warning labels to make a difference?
So I think on their own, no. But I think as part of a wider package, yes. Because and like you say, it depends on how they're delivered. So they need to be absolutely free from any influence of people who've got a vested interest in increasing profit and sales from alcohol to be really effective. We do work across the North East where we're raising the awareness of the public of the link between alcohol and cancer, for example, because we know that public awareness not necessarily will drive a change in behaviour, but will drive a different discourse that we can have with our communities around the things that we need to do to be able to protect them from the harm that's caused. So it absolutely on its own won't work. But if you look at what we've learned from tobacco, it is that, you know, there are the best buys that we know about really clearly, but there's a whole range of things that happened over many decades that have resulted in the lower smoking prevalence. And hopefully over the next few years, if we get the tobacco and vapes bills through, that actually will, you know, end up, you know, taking tobacco products off the market completely.
Can I just push you a little bit on that idea of kind of focusing on the cancer message on labels? I mean, you mentioned about smoking and cancer labels. I mean, the alcohol isn't smoking. I think it's 1 in 2 people who smoke will die from smoking. I think when we did the work that informed the UK's drinking guidelines, we found that even among heavy drinkers, the proportion who will die from their drinking is much lower. So is there a risk we're just fear-mongering a little bit when we say shout about alcohol causing cancer. I know in the North East there's been campaigns showing a tumour in a glass. Is that just scaring people for risks that are actually for individuals are relatively small?
Well, so I mean, interestingly, that campaign in the North East has shown from the evaluation that we've done of it that a certain proportion of the people actually reduced their drinking or cut down their drinking as a result of seeing that. And I think that what we've also seen is an increase in awareness. So I think it was around 20% of the population were even aware that alcohol caused cancer. So I think it is more about how we change the discussion around alcohol. It isn't just about othering. It isn't about those people who are turning up in our clinics with addiction or with liver disease. This is about us as a community and us as a population. So I think that it's why you use those tools and those messages. It isn't necessarily to make a difference at a population level on drinking, but it's to change the narrative and the discussions that we're having so that people start to ask to be protected in the way that they did when they understood and learned about the risks between tobacco and cancer, albeit a different level of risk.
Actually, what I see in my clinics are people who, you know, look like me, like us. They are working individuals. They've got they're drinking at harmful levels, not necessarily dependent drinkers. Who've got decompensated liver disease, life-threatening liver failure. The cancer situation is a very important one you raise. Today's World Cancer Day. There was a national cancer plan unveiled by Wes Streeting this morning. I didn't hear the A word mentioned once in any of those discussions, and yet there's a big paper in Nature Medicine yesterday that was very thorough analysis. 4% of cancers globally are caused by alcohol alone. It's the third commonest modifiable risk factor. So these are facts that I think, despite the suggestion that education isn't effective, the right education is not getting out there. These are very clear, I think, in my opinion, inarguable facts. And I think those are things that we could maybe leverage further. But making the risk more real to the individual is another opportunity we have.
Yeah, and I think we need to get this kind of message right, that it's the information, the education only works if you get the regulation right as well. It's no good telling people you need to drink less alcohol will mean less risk to your health, and then them walking around the corner and seeing 20 adverts for alcohol products and being able to go into a shop and buy extremely cheap alcohol, extremely strong alcohol that is decorated around the shop and heavily promoted. We've just got a complete mismatch there between information and environment. Yes. And one of the biggest things that's been done to try and tackle that in recent years was minimum unit pricing in Scotland and also in Wales as well. Peter, can you just say a little bit about what we know about the effects of minimum pricing from the evaluation of that?
Yeah, and so that measure came in, it was thoroughly researched, tested through the courts, was introduced initially in May of 2018. And during that period, actually between the introduction and the pandemic, we were able to show that hospital admissions fell. There's good work in Glasgow on that measure. And we've seen that in comparison to other benchmark countries, in particular England, Scottish rates of alcohol mortality have fallen, estimates by about 10 to 15% decline in alcohol mortality, most of them liver disease. But this was a public health measure that actually predominantly benefited the people living in deprivation, and that's been really one of the most satisfying things for me personally, I have to say, is to see that gap narrowing. So, I mean, enormous amount of work done and an enormous amount of discussion about it. And actually, it's all pretty much worked out as you would have predicted.
We've talked about many of the problems that alcohol causes, but what's kind of behind those problems? What's driving people to experience alcohol-related harm? What are the factors that influence?
Well, I think if we think about it at a basic level, what is the causes of harm? And it's a combination of how much people drink and how often they drink. And that works at an individual level within the guys you see, but also at a population level.
I think there's also a massive stigma with it as well, which prevents people from being able to acknowledge and admit that there is something that's wrong, or that, and I think that again, that's a narrative, I think, that's been developed by the alcohol industry, that it's about irresponsible drinkers. So therefore, if you can't manage this addictive product, then you are somehow irresponsible. You know, and I think that narrative plays out in the way that people are responded to when they go into healthcare services, when they access services. Lots of people who I've spoken to who are in recovery have said that first step of admitting there was something wrong was really difficult, because it meant that they had to acknowledge that they had the stigma that they somehow hadn't managed this product that everybody else manages. You know, and I just think that narrative of responsible drinking is something that we absolutely have to challenge, because it is an addictive substance. You know, it is something that we should be controlling in a different way to protect the population. And, you know, the idea that we are followed by that industry narrative is really challenging.
I think it was Clive said earlier that part of alcohol-related harm is driven simply by how much people drink, how often they drink, and so on. But as I said in the introduction, we also see in more deprived groups, they're less likely to drink overall. They drink less if they do so, but they suffer higher rates of harm. And we don't fully understand what drives that difference, whether it's that those groups have some kind of vulnerabilities from their living conditions, from living in poor quality housing, from living more stressful lives that make their body more vulnerable to harm. And you were talking about I think you were talking about slightly different communities than just deprivation there. And I think, do you want to just say a little bit more about how, from your perspective, different communities are at kind of different kinds of risk from alcohol?
Yeah, it's very hidden. So I think in certain cities it's being addressed more. But I'm talking about marginalised communities, which are often put under that category as hard to reach, you know. And because they're hard to reach, they're often left to their own devices. And within those communities, things like alcohol are very taboo, especially as in my case, woman, you know. I only know of the women drinkers because I've come through that sort of pathway of addiction and getting help. So a lot of people do it in private. They do it secretly. You know, they never access that help. And in that, their children are suffering, you know, especially with my children. I know that they, for a long time, had to pretend nothing was wrong, you know, because they were afraid of what people would say about me. You know, my family, even though my family knew there was, you know, I had a problem, they had a status to uphold. You know, within our my community I come from, status is everything. You know, maintaining this picture-perfect image of the family is paramount. You will defend that at all costs, because what's the opposite? What will happen if people knew? Stigma. So in my community, stigma is like a tattoo on your forehead. Not just on your forehead, the whole family's forehead.
One of the things I did want to cover in this session as well, though, is just what have we kind of seen change in alcohol problems over the last 10 to 20 years? Because I think things have shifted quite a lot, in some ways for better, in some ways for worse. And it might be good to just talk about what some of those changes might be, if anyone wants to take a stab at that.
I think the biggest change is the age profile of the rates of harm that we're seeing. The upward trends are in older age groups, and if anything, we're seeing downward trends in younger age groups. But yeah, I think it's the change in the age profile. There's defensiveness about that. I think it's a defence against stigma. Oh well, it's not me, it's them over there. So I think the change in age group is one of the very biggest things we need to get through. And
to kind of nail down that point, young people, for every year of survey data we had until relatively recently, the young adults were the heaviest drinking population by some distance. That's no longer the case. If anything, they're the lightest drinking population now, and the heaviest drinking age group are middle-aged people, and also we're seeing big increases in drinking in older age as well. And by older age, I'm not just talking about people in their 60s, I'm talking about people in their 70s as well. That generation that kind of drove up alcohol trends across the 70s, 80s and 90s are now in older age, and they've carried on drinking at the same levels. We're coming towards the end of the session. Does anyone else just want to add in any more points about what we've seen change over recent years?
Yeah, so I think the pandemic was a really interesting time, because we had a natural experiment where we closed all of hospitality and we looked at the harm go through the roof. And I think there's been a real shift of people drinking in establishments, which is often, again, what the industry says is the bit that needs protecting, to actually drinking in a way that was incredibly harmful at home. And, that shift's happened over many decades, actually, in terms of the proportion of alcohol that's drank in the home and out socially in pubs. And I think we need to have a different conversation around the things we need to do to protect people from at-home drinking and to protect people from social hospitality drinking. Because I think, like I say, we would never have been able to do that experiment that we had during COVID, but harm went through the roof. People didn't have the purpose or the structure in their day, and they had access to alcohol, to whatever extent from supermarkets. And I think that shift is something that we probably need to consider in thinking about when we're thinking about the policies that we need to put in place to protect people.
Yeah, I think your question about what's changed, I think the preoccupation, certainly pre-COVID and quite some time before that, was around binge drinking and who was binge drinking. There was a lot of concern and people were, discussion and, what should we do about this? And I think the sort of populations that people were worried about in terms of binge drinking now are probably those ones that are not drinking so much. But I think Alice's point about people drinking at home and drinking more regularly, because that shift, I think, has happened to that regular drinking and drinking at home. You're not buying a pint, you're just getting yourself another drink. It's sort of unregulated. Mm-hmm. I don't mean regulated in the regulation, but you're unregulated.
It's no kind of social control.
Yes, that's right. Yes, and I think that's a change, isn't it? And of course, you can just pick the phone up and order it. Someone comes on a e-scooter and delivers it to you. You don't. It doesn't matter if you've run out and you're not going to the supermarket till next Friday. You just pick the phone up. Everyone's got a phone. So everyone's got pretty much 24-hour access.
And there's no safeguards then. So, I mean, the one thing I always think with licensing is at least there's a safeguard that the bar shouldn't serve to somebody who's intoxicated. I'm not saying that never happens. Whereas at home, that safeguard is not there. And actually, we have seen people dying where I work, where we've looked back, and it's because they've had multiple deliveries from somebody in a 24-hour, 48-hour period with no safeguards around whether they were already intoxicated or not when it came to it. And I think that is a real challenge. It's just there 24/7.
Kind of a slightly more provocative question. Has the debate gone a bit stale around alcohol policy, and do we need new ideas? And are we seeing new ideas in alcohol policy? Yeah.
I think to quote a phrase that I've heard in open meetings is that the trouble with the truth is it's always the same thing. So I don't think we can divert from that message. I think we need to stay on it. We, of course, don't always persuade policymakers, but at least they need to know what they ought to be doing, even if they're not doing it. So I don't think there's an argument for diverting for that message. You need to find ways to present that are going to fit into the context and so on.
But we have got some new measures new ideas being developed. Julia, you've been working a lot on alcohol care teams as a relatively new approach to alcohol. Do you maybe just want to set out whether we feel that's offering something new?
Thank you. I think in some ways, and as somebody who runs an alcohol care team, an alcohol care team is part of the sticking plaster because the rest of the system is so broken. Yeah. Sad to say. Because essentially what we have is we've had a treatment system that's now been massively underfunded for 12 years. A lot of the expertise has come out of it. So the people who are at that, the very much the severe end have had very little in the way of treatment. And it also means, as happens with all health conditions, is that and or social conditions is that as things become more and more scarce, the people who access them are more and more severe, more and more complex, and less likely to have a positive outcome. And so you start to get this perfect storm of a vicious cycle, which is, oh, there's alcohol, you can't do anything about it, we'll further disinvest in treatment services, there's no point having expertise in the system because it doesn't work. So consequently, where alcohol care teams came from was the fact that actually probably 95% of all alcohol medically assisted withdrawals are currently happening in an acute hospital by non-specialist staff. Ooh, blimey, okay, let's try and do something to mitigate the kind of the cost that is. And it's worth remembering that when NHS England set up the kind of expansion and trying to make more coherent alcohol care teams, the single metric outcome was about preventing repeat admissions within 30 days. So we're going to put, say, 3 nurses in each hospital without funding any strategic clinical leadership. And as part of that, the only evaluation is, has it prevented readmissions? So whilst I think alcohol care teams have a huge opportunity for improving care in lots of different ways. They can improve care in terms of direct to the patients that they're looking after. And the evaluation we're doing at the moment, you know, and the evaluations that have happened in individual hospitals always come out with the fact that actually patients say, thank God there was somebody who treated me like a human being with a proper condition, who was in need of help and tried to help me get it. So I don't think anybody doubts the fact that if you put an alcohol care team in, it will improve patient care. Hopefully, it will also improve the care that the hospital offers. But the evidence that we're getting back from that and the early results is that actually people are still not doing screening. They're still, therefore, not getting the data. They're not implementing universal screening about things. And also, the other thing is that people are coming in more complex. And the average length, the median length of stay of people coming in for an alcohol-specific admission is 2 days. Now, in 2 days, you can't assist somebody from, medically assist somebody from withdrawal. You're probably unlikely to change their trajectory. And then where do you put them into this? So I think alcohol care teams, I'm not knocking them, by the way. I think they're a very good idea. But actually, as part of that, we mustn't have what we've had, and we've talked about with other aspects today, which is that it's a bit little. It's kind of saying, well, we'll try that in the absence of anything else, and we think that sticking plaster, be it alcohol care teams, labelling, all of these things on their own is going to suddenly solve it. Oh, it didn't solve the problem, therefore there's alcohol, there's nothing you can do about it.
I want to come, though, to one other kind of area of shiny new things, which is alcohol-free and low-alcohol drinks. And I'll maybe come to you, Alice, as to whether... I mean, Alice is probably looking slightly nervous because she knows I've been doing a massive research project on this. But what's your take on it? Do they offer some benefits? I mean, and are there risks as well?
So I have no problem with them being there at all, but I don't consider them to be part of any solution that we might have to tackling this problem that we've got now. My real concern is that this is being presented as a solution. It's being presented as a solution by the industry because they know that they can continue to market their products. By putting 0.0 on it in Ireland, it's meant that we've still been exposed to brand placement and marketing which normalises alcohol products. And I think that is the problem. And actually what we have to understand, the industry has a duty to their shareholders around profit. So they are focused on how can we increase profit. So they're not wanting to replace our alcohol consumption with no and low. They're actually wanting to replace our drink of Diet Coke or our, other thing with no and low. So rather than having a Diet Coke, you'll have a beer. So I'm not saying that they shouldn't be there, but they're not going to be a solution for us. And I don't think that we in policy should be getting anywhere near involved with marketing these products. They are perfectly capable of marketing the products on their own. They don't need our help. And actually it is being sold as a solution. And I just don't make that connection with it.
But is there an argument that one of the key things we know about those products is they're mostly being drunk by people from higher socioeconomic groups, better off people. And as we've talked about, the harm is predominantly concentrated in lower socioeconomic groups. So if there is any benefits from these products, is one of the things public health professionals, policy should be trying to do is making sure there's take-up of them in lower socioeconomic groups, or trying to make sure they're more affordable to lower socioeconomic groups?
Like, again, I don't think we should be getting involved with industry. I think industry is perfectly capable of marketing their products on their own, and they aren't affordable.
But
You know,
industry won't necessarily do that bit that we care about in public health.
But I don't think they'll do that bit if we push them to do it, unless it's regulated and they have to do it. They will pretend to do it as a voluntary thing, which we all know doesn't work at all. And I think that the risk of harm for me is greater than the benefits. And don't get me wrong, I've spoken to some people who've, you know, successfully used them as an aid to help them to stop drinking, or to feel that they're still socially acceptable in a group when they're not drinking. So I'm not saying there isn't a place for individuals, but I think if we think about it at a population level, you know, I just think, you know, it's David and Goliath. We are battling with the industry. You know, I think we've got a responsibility to continue to say the things that will make the greatest difference, and not getting involved in the peripheral bits that allow the industry to delay the things that make the greatest difference.
So as well as NoLo drinks in the general population, obviously they might be used by kind of clinical patients, people who are experiencing problems with alcohol addiction or with liver disease. So Gautam, I know you've been looking a little bit at this in your work.
Well, yeah, we have. So I think so the first thing I would say is that we don't have good data for this population. I think that's the first thing to say. I mean, you've made the point already that they're generally being used by the slightly higher, well-off individuals. For my patients, they're on a different timeline. They need to stop drinking, and stop drinking very soon. Otherwise, they're going to die. And so I think there is a need to be a bit more innovative in what we do and the approaches we take. Having said that, the current position is that if someone, for example, is on a liver transplant waiting list and there's absolutely no use of alcohol replacement drinks, NoLo alternatives, and they're not typically recommended by any society, but I think there's an evidence gap here that is worth addressing. I personally think they could be a useful tool, but I think we should probably establish whether there is harm that is associated.
I mean, that's really interesting. We wrote a piece on this in Addiction Journal recently with a couple of hepatologists. And part of the reason those hepatologists wanted to get involved is because they have patients coming into their clinic saying, I'm using these products, I feel really great. It's really helping. It's the first thing that's ever helped me. And then the clinicians are having to say to them, you shouldn't be using those products, stop using those products. Yeah. I mean, how do you deal with that as a clinician?
Yeah, so you're quite right. That's exactly the paradox that I also have with some of these patients, because they do come with, they've naturally, organically found these alternatives. They've started to feel a bit better. They're receptive to the message that they must stop drinking. It's very different when people have an established condition. It's secondary prevention. It's different for the individual. The motivations are different. And so for me, this is something that I think is worth studying, because I've had the exact same anecdotal experience from patients too. And I think there's a whole separate message about what are the motivators for abstinence in these high-risk individuals. But with NoLo in particular, I think there's a very strong case to try and generate evidence to answer that question one way or another.
Yeah. And what about the other kind of sharp end of addiction, Julia?
Well, I see many of the same patients that Gautam sees, but I think what I would absolutely agree with is that we have inadequate evidence at the moment for where this fits as a kind of helpful or unhelpful product. The first thing I would say is that we absolutely need to differentiate what is a no alcohol product from a low alcohol product. And as with units, it's different in every country. And so consequently, in the United States, you can call something no alcohol, which contains 0.5% alcohol. In the UK, it's 0.05%. And from a liver point of view, it is probably helpful to be drinking something that is substantially less. But actually, from a brain point of view, there is a huge difference between whether something has zero alcohol in it or whether it's got some alcohol in it. And so when the patients that I see, which are often the patients that you see as well, I would say there is no evidence. But I would also say the thing to do is to probably, for people who've said, well, what do you think about this? I have to say, I see patients for whom this is the absolute solution, unless they're on a liver transplant list. And despite the fact that there's no evidence, they're not allowed to drink them. I think that's a separate question. And for other patients, actually, it has just been a cue and a trigger to go back to full-blown drinking. And so I often ask patients who are in early recovery, who are interested in exploring this, to go and do a little experiment, come back and tell me how it is, and to support them through that. And if they're finding themselves, that they can have a single drink, or chap was telling me, they can go off to a barbecue with their own 0 alcohol beer, and they can then pour it themselves. They look like everyone else. They feel they're socially inclusive. They will just drink one over the course of the day. Whereas for other people, actually, they're on their 5th can of an evening and they're trying to suck something out of it that is absolutely not in there. And I say to them, this is your brain saying to you, smells like alcohol, looks like alcohol, tastes like alcohol, but where is the alcohol? Just keeps it clear of them. And I think until the first thing we absolutely have to do is separate no alcohol products and low alcohol products, because we're just feeding into the industry to say NoLo. And what we're including in that is then it will be everything under 2.5%. And then we will move to, like we did with Philadelphia cheese, anything that isn't full fat, 8% beer, is suddenly low alcohol beer at 6%.
We actually see that in some of the literature. Some of the work that's been done on NoLo drinks actually considers beers up to 3.5%, which is, that's John Smith's. That's a standard bitter. It's not NoLo at all.
Yeah.
And yes, the alcohol industry have pushed for that definition of low alcohol to be raised to 3.5%. One of the things I wanted to pick up with you, and it kind of speaks to what Alice was saying before about marketing, is we get marketing for alcohol-free drinks and also the drinks themselves, which are a form of marketing, the label, the brand, and so on, in places that wouldn't normally have had alcohol, so what we might call alcohol-free spaces. Is that problematic for your patients?
Well, I think it's hugely problematic from an industry perspective, and I think again it's really important that we don't talk about my patients as being a sort of different group. I think we need to think about this as different risk groups. And John, you did some really good work presenting a draft sort of policy for where we might advertise this. And I came to a talk that you gave, and it was really helpful because the following day I was teaching psychiatric trainees. And there was already the debate about, should you allow NoLo? And I separated that. I said, no alcohol if you're going to do this on psychiatric wards. Can you now bring into a psychiatric ward, where you've got people detained under the Mental Health Act, 0 alcohol? Because there's no reason not to. So I think, coming back to Alice's point, which is the market's going to let it look after itself. Let the market look after itself. We need to be really clear as public health practitioners, as clinicians, about what we do know and don't know about these things and how they might help or hinder certain conditions.
Yeah. I mean, the evidence is really messy on this. We've got some studies that give fairly strong conclusions that actually, this is reducing alcohol consumption. When you see a launch of a alcohol-free beer or a low alcohol beer, alcohol sales go down. Except some of the stats, when you look at it, is a bit suspect. I'm not sure I believe it. We've also got qualitative studies where people provide beautiful accounts of people who've had these great experience of alcohol-free drinks, but they tend to be coming from kind of the positive sobriety community, the mindful drinking community, which kind of actively promotes these drinks. The work we've done is increasingly showing actually it's a bit less clear than that. It's not that we're seeing that there's no benefits, it's just that we can't quite pin down what the benefits might be. And it might actually be that what's happening here is that people who were cutting down anyway are finding these drinks helpful, but as alternatives to soft drinks rather than alternatives to alcoholic drinks. And what we're not clear, well, maybe that's making it easier to cut down, the process easier. And again, that's also not clear. So I guess the reason I'm a bit more, I guess positive's the wrong word, but a bit less negative about them is just the evidence is really unclear. In theory, they should be beneficial, but in practice, it's been quite hard to pin down what those benefits are.
And I'm not negative to them. As I said, for some patients, they're absolutely the solution. But I think the one thing that we as researchers, first and foremost, is we absolutely need to separate what is no and what is low. And we should not conflate the two, because in no other area of clinical practice would you mix two things together and say they're the same thing when they're absolutely not.
Yeah. Ali, I just wanted to come to you to see if you had any thoughts on these products. Again, as someone who's got lived experience of alcohol problems and has obviously spoken from the perspective of the different communities as well, how do you think these products either help or create problems?
So for me personally, the only time I was just talking to Peter, the only time I've ever tried one of those is when I went to Dublin, because I've never tried Guinness. Other than that, I stay clear, just because the taste of it in my mouth, it makes me paranoid. It makes me feel like I'm actually getting drunk, even though I'm not. For me, it's like I just don't want to go there. You know, I've been there, I've done that. You know, I've retired from that, and I don't want to go back. And I have seen that for a lot of people who have come, especially when they've come initially into recovery, and they've used, and it may not be the case all round, but from what I've seen, use low products or no products, they've relapsed pretty quickly. You know, pretty quickly.
Okay, great. Unless there's anything essential anyone wants to add. Go on, Peter.
Just make one point that, you know, Norway have regulations that the alcohol-free version that does not have the same name as the mainstream brand, does not have the same branding, does not have the same logo. I think that makes a lot of sense. It makes a lot of sense in getting around the alibi marketing problem that we've had of zero brands being able to be advertised. And I think it also gets a bit round the behavioural thing of for individuals that this feels very close to drinking the master brand, if you like, and the jump is a near one. So I think that makes a lot of sense to have separate branding for these products. And of course, Norway has the advantage of introducing that right at the start. We're a bit further down the story in the UK, but I think that seems to be a very logical response and way to treat the alcohol-free brands.
I think this depends on the alcohol restrictions you've already got in place, because Norway has already banned alcohol marketing, so you have no Heineken adverts in Ireland. In Norway. So having Heineken Zero ones is problematic. In the UK, we've got Heineken or Guinness or whatever adverts everywhere, and actually maybe having those Heineken Zero or Guinness Zero adverts does at least create an alternative for people. It makes them aware of an alternative. And it also says, here is a familiar brand, here is a product that isn't alcoholic that you might want to try instead. We get round that problem that alcohol-free drinks historically have tasted bad, and they're just bad quality products. And they're not nowadays. I think most people accept these are nice products to drink. And at least it's encouraging people to say, here's a brand I recognise and trust. I take on board everything you said, Alice, about, yeah, they're also advertising it in places they wouldn't have been advertising alcohol. They're advertising it in ways that they wouldn't have advertised alcohol. So there are risks there. But I do find there's a bit of push and pull on that. Clark, go on, Clark.
Just a quick one. Given the discussion, isn't it somewhat surprising in the 10-year health plan for England, one of the actions is to support innovation in the no and low market and restrict access to under 18s.
Yeah. And I think
it's been sold in that context as a healthy.
And I think if we believe what's written in the papers, in a sense, that was the policies that was left over after all the effective stuff was taken out of that 10-year plan. We probably should draw this second session to a close. So we've talked a little bit about the different policy areas that we know work around affordability, availability, marketing, and also some of the issues that come up in clinical practice and some of the new policy areas. We're going to go on in the next session to talk a little bit about why it's been so difficult to get those policies into practice, and particularly about the role of the alcohol industry in that. Okay, so this third session is going to look at why it's been so difficult to introduce an effective alcohol strategy in the UK. So most people agree that alcohol creates significant social problems and health problems for society, yet successive governments have been reluctant to introduce any alcohol strategy. When they've done so, they've faced criticism for failing to implement the measures or for focusing on ineffective measures in the first place. And the last attempt, the 2012 alcohol strategy, introduced by the coalition government, looked promising at the outset. It included commitments to introduce minimum unit pricing, proposals on restricting special offers and for getting public health more involved in alcohol licensing. But this kind of much vaunted strategy failed to deliver any real changes or substantial changes in alcohol policy, and it was actually largely dead in the water within a couple of years. So this session is going to explore why it's been so difficult to make progress and get an alcohol strategy. And we're probably going to focus a lot on the role of the alcohol industry. We know that the industry puts a lot of effort into controlling alcohol policy and influencing the way it works through its building of kind of coalitions, its management of information and evidence and the debate, its relationships with the government, and then also at times bringing in the big guns, bringing in legal threats, attacking evidence, withdrawing cooperation. So would someone like to start by giving us a little bit of a flavour of how that actually works in practice from your own experiences? Maybe some of those of you who've worked in either local or national government.
In terms of alcohol, I think when we've touched on this before, the narrative in how you talk about the problem is really important to policymakers. The solutions, I sort of think we've got a lot of evidence around that. The big one now is political will. Mm. So, you know what I mean? And when we look at policies which have been implemented, I know not a strategy, but policies, and sort of Scotland and their alcohol strategy and MUP, the duty to a certain extent, the changes in duty, they happened because a policy window opened and people had to rush towards it. So it doesn't always happen as we think. And then when you've got the attention and people want to do something about it, that's when things like industry influence and what come on. But often strategies come up and they go down. You know what I mean? They're talked about and they never happen, or they're a damp squib. We've had 2 attempts at a liver strategy I can remember, have got nowhere. And a lot of that contained alcohol. Yeah.
So part of it, you talked there quite a lot about policy windows opening and there being some debate. One of it, and we do want to focus a little bit on the industry because I think this is one of people in public health's real key concerns. One of the things that industry does very well is actually managing that process of when, not necessarily when policy windows open, because governments happen, governments change, they have to have strategies on something. But when those policy windows open, what policies are actually on the table in the first place?
Going back, the narrative as well. If you read any alcohol policies at the moment, or reference to alcohol, the 10-year health plan, the men's health plan and other things, they talk about it from an industry perspective in the sense that it's an individual problem. Mm-hmm. You know what I mean? It's not the infrastructure, it's for people to do things about it themselves. Yeah. And they want to give tools to help people make those choices for themselves. So that is cementing a framework that this is all about the individual.
Yeah, yeah. And it's also not about, the problem is the people, it's not about the product or the people producing that product. Yeah. It's not about the price that alcohol is sold at, the availability of alcohol, the way alcohol is marketed. It's about the way people consume alcohol. Alcohol is not the problem. The people consuming alcohol is the problem.
Yes.
Yeah. And there's a lot of work goes into making that debate, that framing of the argument happen. It's not just about, here's a policy proposal, the industry comes in and lobbies against it. It's much more subtle than that. Alice, you're nodding.
Yeah, I'm just thinking over the last 2 years. So there was a health select committee that was looking at alcohol harm, and the first people who were invited to speak to ministers on alcohol harm were alcohol industry funded bodies. And the way that they framed the discussion was around the things that they know will have the least impact on, on population changes in terms of alcohol consumption. You then look to the work that was done last year, where the Licensing Act was reviewed by the alcohol industry, who obviously want to find a way of selling alcohol products more easily. And that was all kind of agreed and accepted by government. And then the most recent 10-year plan for the NHS, we had whisperings that minimum unit price might be in there, and really hopeful that DHSC colleagues certainly were thinking that this was a good idea, and actually we need it for the NHS because we can't continue responding to harm. We need to start thinking about how we really act on prevention. But the Institute of Alcohol Studies demonstrated through a Freedom of Information request how active industry lobbying was in the lead up to that 10-year plan being published, not in DHSC, but in the other departments across government. And actually the narrative that alcohol is good for our society as a whole was something that's perpetuated. The narrative that the hospitality industry has been so affected over the last few years by people, you know, drinking in different ways. When the reality is it's because more people are drinking at home because of cheap supermarket alcohol. But actually there's a spin on it because the producers of alcohol, duty to their shareholders to increase profit, you know, have to focus on what are the things we can do to sell more alcohol. So actually having them round the table in that space, to me, I can't understand why anybody thinks that's okay. But then I did have the opportunity as part of my job to go to each of the party conferences a couple of years ago to talk about the issue of alcohol harm. But alcohol was everywhere you went. All of the sessions that were really well attended provided alcohol in them. You know, so we're asking people to make policy decisions without having necessarily the right information, because they're given misleading information by people who have a vested interest in profit, who are actually also the people who are the consumers of alcohol in the first place. So it's those bits around actually how do we start to change that narrative? And we really need some brave politicians that are prepared to say, actually, community health for me is more important than the noise that we'll get from implementing some of these challenging policies.
I would just say if you look at the way in which tobacco policy is protected by the Framework Convention for Tobacco Control, you need something like that for alcohol. I would say you need something like that for all the, you know, the real harmful public health agendas, because you then can operate in a policy space where there is no influence, and you curb the influence of the industry, and you can remind senior people in departments and politicians that it is inappropriate to be engaging with the industry. And I think, and that's probably a bit boring to people, but I think without it, we'll be forever doomed with influence in some way or other. It's insidious.
Mm-hmm. Can we win that argument though, that alcohol should be treated like tobacco? Because it goes back to that point I made earlier, that tobacco is kind of seen as this exceptional good.
Well, it's exceptionally harmful. It locks people in poverty. It contributes to underachievement of children. It you know, there's a lot of violence associated with alcohol. Why would we not want to do something a bit differently that gives us an opportunity to get some of the potential policies shaped into a strategy that, without the influence of industry, that government might be able to hear the messages loud and clear that this is something that needs some sort of step change in the way in which we deal with it?
I don't think that alcohol is completely different to tobacco. I just think we're several generations on from the work that we did on tobacco. So we were chatting at lunchtime, and I was saying, actually, I remind myself every day that the public health people in the 60s, 70s and 80s had to do exactly what we're doing now with, you know, alcohol, ultra-processed food, gambling, you know, those industries that have a vested interest in profit rather than health. And so there's something around, you know, making sure that we maintain our tenacity and our focus on these things, because actually they're the only things that are going to make the difference. Yeah. And it isn't going to be one thing that falls overnight. It's going to be a whole range of things that come together.
Yeah, and I think there's work that we can do to make the industry tactics more explicit. So this isn't just an ideological thing, it's a practical thing. My early story from the Scottish story was that, so we'd taken, you know, in Scotland, if you're from a medical organisation, you have pretty direct access to ministers, maybe one of the advantages of a small country. So we took they weren't called the best buys, but we took them to Scottish politicians and they were attracted by the idea. So we taught them through price availability marketing. So the minister responsible said to me, really interesting, you know, meet again to talk about it, but I'm meeting the industry next week. And I said, well, I'll tell you what they're going to talk about. They'll talk to you about underage drinking. They'll talk to you about drink driving, one sober driver, problem solved. And they'll talk to you about drinking and pregnancy. They won't talk to you about men. They won't manage chronic health harm. And two words that you won't hear, one is supermarkets and the other one is vodka. So we met 2 weeks later and they said, you were absolutely correct. That's exactly what they talked to me about. So that gave us some credibility, but I think it also showed them about the way that the thing can be taken for a walk. I remember that session you were talking about, Alice, where the industry just talked about having a conversation within the family about alcohol. They spent about an hour talking about that. So I think making explicit what the industry tactics are and just those diversions and deflections and shaping the thing. So, we had a favourable set of circumstances, people who were willing to listen to the message, but it was just off the top of my head. I took a bit of a risk, but I think it really worked in saying this is the tactics that they'll play and this is where they'll try to take you away from. And I think that had a bit of an influence on what then happened afterwards.
I kind of saw, I think Greg Fell on LinkedIn talking about this recently. I think he used the phrase pre-bunking. So rather than debunking some claims after they've been made, building in your arguments before they're made by the industry in the first place. Clive, you were going to come in.
Yeah, just a couple of points. I think on that point of industry interference, it's not just ministers, it's civil servants. And I think there's a way of managing that, because if you think about policy battles, if you like, or it's a battle between interests and how you want to serve those interests with ideas. And obviously industry comes from one place, profit. Public health comes from another place in terms of protecting and improving health. I think locally you can put guidelines into place which sort of prevent industry having input into health. But the other thing is across government, how industry is seen. We view them in one way. For government, their economic growth is the game in town. They are part of that. Every time the UK signs a trade deal, I can guarantee there is a minister in a Scottish distillery promoting Scotch whisky. So, they're big employers. And I think we have to remember that. They are, part of the economy. So you're not going to dismiss the industry, but how do we protect health from industry interference?
And government has its own kind of conflict of interest in it as well. Government gets something like £15 billion in tax revenue from alcohol every year, and it needs that money, particularly at the moment.
Yeah.
And certainly in recent years, as the government finances have been constrained, we've seen the alcohol industry really making that case that if you try and reduce alcohol consumption, effectively you're reducing government tax revenue.
Yeah.
The duty reforms, they claim, had a massive hit on tax revenue. Now, there's actually evidence to show that's not really the case, so that the decline in tax revenue long predates the duty reforms. But yeah, so government has this real conflict around what the different departments want. The Treasury wants tax revenue, the business department wants to grow the economy, and whereas the health department's trying to reduce harm, but is fighting against other parts of government in doing so.
But civil servants move around,
Yeah.
and their mindset comes with them. Like, civil servants can be the best friends when you're trying to get something implemented, and making the right contacts is really important.
I also think, though, that we never talk about the cost to the, well, we do. We talk about the cost to the economy, because 15 billion there, 27 billion spent tackling the harm that's caused by alcohol. And that actually a large amount of that is within, the economic frameworks, whether it's because people are dying during working age or they're too ill to work, or, the presenteeism or absenteeism that comes from alcohol. There's a significant proportion of that 27 billion pounds that is actually economic harm. And, we know that when we think about that, we often think about the amount of money that it costs to treat illness from the alcohol perspective, but the economic damage is far greater.
Yeah. The days lost to days absent from work, from healthy life years lost. We talked earlier about people dying in their 40s and 50s from liver disease. These things really matter to the economy. We have a very sick population, as we talked about a lot during the pandemic.
Yeah, and intergenerational transition as well. That it's all really obvious and apparent if you look at, groups of kids who are not doing well in the school system, in the care system, you can probably find some trace back to alcohol somewhere.
Yeah. But I want to come and talk in a moment about some of the other reasons why policy is so difficult and perhaps some of the aspects of whether the public support policy or not. But one other point that's worth talking about with the industry is the way they use legal threats as well. So we saw that in minimum unit pricing. They held up the policy for 6 years. And even though they lost that legal case, arguably they achieved their goal, because when minimum pricing was actually introduced in the end, it was introduced at the same level that it was planned to be introduced originally in about 2010, which was inflation meant that level was much less effective than it would have been. I think we found it would have been about 70% of alcohol would have been affected had it been introduced in 2012, and it was down to about, I think it was about 50% by the time it was actually introduced.
Yeah, and I think one of the other motives behind the delay was a hope for political change. Yes. A hope there'd be change of government. Now, there wasn't, but it's, punting the ball up the park, to buy yourself time kind of thing. So, and again, one of the things I think we were fortunate with in Scotland was just with the individuals who were involved, the more the industry threatened, saying, and their initial approach was, well, you're a relatively new government, you're ambitious, we know you want to do this, but take it from us, this will never happen. Now that could have had a chilling effect on them saying, well, let's just drop it. But in fact, just with the people involved said, well, we'll show you, and it could have gone the other way, but it went the way of people actually wanting to test out that the government had the power to do that. And it turned out they were right, they were correct. But yeah, the delay was a big, reducing the impact of the measure, hoping for political change, and also putting the frighteners on government. And we were just lucky we had brave people who were willing to see it through.
And I think it put the frighteners on other governments as well. I think regulatory chill has sort of come across the border and probably around Europe.
Yeah, and we see that a lot in local government and in smaller countries as well. Scotland was fortunate that actually the case was defended by the UK government because it was the UK government that was taken to court effectively.
It's the cost of that though, isn't it? So at a local level, you really are restricted from what you can do because as local authorities, we have no money to defend any of these big business, So we were looking at an alcohol licence application that was wanting to sell alcohol from 8 in the morning instead of 10 in the morning. And, and we provided local data to say, actually, this would be a really bad idea for the place it is in Gateshead. And actually, but the local authorities stood by it and backed it. But if we'd ended up in court, it would have been really problematic and difficult. So it puts people off doing it. And the other thing I was going to point out was Mark Pettigrew's research that looked at the alcohol education programme that was going into schools. He was written to and threatened by the alcohol industry not to publish that research. And thankfully, he was brave enough and went ahead with it and nothing happened. But the point is that they're constantly doing this sort of thing.
And we experience this as researchers as well. We, almost as a time-wasting kind of exercise, producing critiques of our evidence, and we have to spend time responding to them. We're not spending time doing other things, dealing with vexatious freedom of information requests for research data and so on. So it's fairly clear, the industry is in lots of different ways shaping this debate. I wanted to talk a little bit about the kind of public and political debate as well. And Alanie, we kind of hear this debate about nanny state a lot, about the government doesn't want to introduce nanny state policies, or the tabloids criticise policies as nanny state. Does that still feel a fair representation of where the public are, or are the politicians a little bit out of touch on this?
I think it's a bit of both, to be honest with you. I think there's some people that would be like, this is great, especially if they've seen it within their own families or within their own circle. And then there'll be others like, we're not like those people, so why are you penalising us? A bit like we've discussed, that they're the ones with the problem. We're drinking responsibly. We're getting punished. Seeing it as a punishment rather than seeing it something that reinforces health.
Yeah. And we talked a little bit about the kind of political will earlier as well, and then also about the costs of alcohol-related harm. And a lot of that kind of will and those costs fall on the health service. And I guess, do you see those impacts in your daily life, Gautam? Do you see the sort of sense that, Christ, the health service is having to deal with all of this stuff when it could be doing other things?
So simply, do we see the end result of all this increase? Yes, of course we do. Absolutely, as I've said, there's very notable changes in both the number of patients and the type of patients we see that have got alcohol-related harm, not just dependent. But I do also want to echo this point. There is this sort of broad shift in awareness of alcohol-related harm as well. In parallel, there's more public members and patients who have an understanding that alcohol causes several diseases and can cause chronic health problems. I don't know if it parallels the broad rise in gut health awareness or well-publicised cases of alcohol-related harm. I don't know, but I think both things are happening at the same time.
Yeah. And then I guess one of the other economic factors in play here is the cost of living crisis. So if we're talking about reducing the affordability of alcohol, the way this often gets framed is we want to put the price of a pint up when people are already struggling. We're tackling the working man's drink when the working man is suffering. I mean, some of this feels a little bit dated, but some of it also feels quite real, that it's really hard to make a political argument to make things more expensive during a cost of living crisis.
Yes, it is, but I think it's not a level playing field, is it? You know what I mean? The industry, they're pushing strong, cheap alcohol, which is causing a lot of the harm, and so I don't think, from your own research, John, people understand what it's likely to be for them. So those people who are drinking at a lower level are minimally impacted in terms of pricing, as we, Scotland, what have you, even the 65p, so it doesn't affect the pubs.
And it doesn't affect moderate drinkers.
Yes.
Who are even moderate drinkers on low incomes, because they just don't buy a lot of the cheap alcohol that's affected. Yeah, Julia.
I'm just going to challenge you on that word, moderate.
Yeah.
So what do you mean by a moderate drinker?
I mean what we now call a low-risk drinker, but people who are drinking within the Chief Medical Officer's guidelines, essentially. Low risk, lower risk, yeah.
Those are not moderate drinkers. And I just do challenge you on that, because that's, I think, part of this narrative, which is, so what's the opposite of a moderate drinker? It's an immoderate drinker. And coming back to your things about some of the stigma and shame in women and stuff, you're immoderate. I mean, that has all sorts of historical undertones for women and moderacy and immoderacy. So I think there is that thing about moderate drinkers. No, lower risk drinkers, we need to be much clearer about what we're using, because moderate plays absolutely, it's the same as responsible. Moderate stroke responsible equals the same thing, equals the industry message.
Yeah, and that's really important. The other bit I wanted to touch on before we finish is actually some of this is about ideology as well. Some of this is about just what do government ministers actually believe? What do they want to do with their time in government? And we've had, until 2024, we'd had 14 years of a Conservative government, and we'd expect a Conservative government to be less in favour of restrictions on people's freedom to do what they like. How big a role does that kind of political ideology actually play in the difficulties we face in alcohol policy?
Yeah, so I think that's huge, and I don't think it's just in politics. I think that's what people are told as well, that this is about their free choice. But I think that people who think they actually have free choice are naive at best, because actually the world around us has been shaped by the industry. They have millions and millions and billions of pounds more than we have to be able to balance that. And I think governments have a responsibility to try and level out the playing field so people do have a bit more of a free choice without walking around the corner in the supermarket and seeing the alcohol advertising next to the back to school display, without looking at the no and low alcohol next to the really strong beers, without going into the cinema or going into a soft play and being served alcohol. We are not in a place at the moment where we have free will in the way that we behave, which is why, as a population level, our societal trends have changed.
Yeah.
Isn't there the economic model fits into that as well? We've had a sort of neoliberal economy for many years, and it's the market rules. And we can leave it to the market. People make the best choices with their money, and we can leave it to the market. Yeah. And which we know it doesn't.
And that works to an extent in certain parts of the economy, but it doesn't work when you're talking about an intoxicating product, an addictive product, and a product where kind of the public health messaging or kind of counter messaging is being grossly outweighed by alcohol marketing, and also when we're talking about lobbying or advocacy or political influence. the number of people working on alcohol policy within public health is actually pretty small compared to the resources that the alcohol industry brings to bear on this.
Tiny.
Yes.
Tiny.
And even tinier now, it's getting less.
Yes.
Yeah.
Tiny and susceptible to alcohol industry influence because the industry has access to civil servants. They expect to be able to ring up and have a conversation and to meet with and, in brackets, be influenced by. That's for gambling industry, alcohol industry. It happens all the time, I think, unless there are very strict or principled practices that mean that you don't take those calls and you don't engage and they aren't part of the conversation. But it's quite easy for them to breach those expectations of policy without influence of industry.
So I think we need to finish that session there. And I think the key point to kind of come out of it is the alcohol industry's ability and range of influence over public health and alcohol policies is surprisingly wide. But there's also other things going on as well. There's mixed public support, there's issues of political will, and there are genuine economic considerations and trade-offs in there as well, albeit we know that alcohol is contributing negatively to the economy in general. So we'll leave that one there. Thank you. Okay, we're going to finish today by talking in a bit more positive tones about how things might change. So we focus a lot so far on the challenges facing alcohol policy and public health advocates in the UK, but are there some shards of light as well? We've had some policy successes with minimum unit pricing in Scotland and Wales. We've seen improvements to the way we tax alcohol, substantial increases in funding for alcohol treatment services. And we've also seen some positive trends in the data amid the more worrying ones. So with young people drinking less, we know they drink less today than at any point they do in previous history. We've also seen more interest in ideas around moderation, sobriety, temporary abstinence, and with some suggestions that public attitudes towards alcohol are shifting. And of course, we do have a relatively new government as well that has a promise to make a radical shift from sickness to prevention. So are we maybe moving into a more favourable era where we might be able to secure a new and more effective alcohol strategy? And what the different groups need to do to support this? So maybe if I can start with you, Auni. What positive trends can you see at the moment that might lead us towards a better alcohol approach strategy?
There's a huge rise in sort of the sober culture on social media. So I'm one of those people, but just people talking about their lived experience instead of someone, oh, that's a dirty alcoholic, like, oh my God, this person's in sobriety, this person's like, someone who we should look up to, this person's an inspiration, and just sort of setting about that positive image around sobriety. And I think what also helps is the other side of lived experiences. It's not just, and I'm talking not just personally here, but even with my own story, I didn't just stop drinking. I went on to achieve some of my dreams. I'm there, a present mom for my kids, and I've achieved things that I never thought possible. People watch that.
Yeah, you told us earlier that you've gone back and completed your degree, and you'd gone on to do a master's, and you're now working in business as well.
Absolutely. And if you told me about 6 years ago when I was in active addiction, that's what I'd be doing, or even speaking publicly about the fact that I am a recovering alcoholic, I'd probably looked at you like, you'd hit your head on something, but now it's so celebrated. So people see that it's not just about putting the substance down. Actually, sobriety equals the key, gives you a key to a whole different life, one in which you can maximise your expectations.
Yeah, and do you think this kind of positive image, either for people who are recovering from alcohol use disorders and alcohol problems, but also for people just cutting down generally, do you feel that sort of more positive image of cutting down is being heard by the wider public as well as those of us who just live in the alcohol world day to day because that's our jobs?
There's been such a positive light around sobriety. not just of putting down the substance or the bottle in this case, but about the life you can build after that. The fact that you're able to be there, active and present in the present moment, being out in nature more, just maximizing on your potential. So even those people who haven't got a drinking problem, they'd be watching these people thinking, actually, maybe I could go and do that, maybe I put the alcohol down, I might be a bit fitter or whatever it may do. There is this real positivity in watching someone build this absolutely amazing life, and you're just watching them, grow into their potential.
Yeah, and I kind of see this as part of a wider trend. I put it together with the decline in youth drinking, the rise of things like dry January. We've seen a lot more talk about moderation in recent years, and we talked earlier about alcohol-free drinks. I kind of put these all together as some sign that as a society, our relationship with alcohol is shifting, and that generation that drank less as teenagers they're now younger adults moving into their 30s in some cases. We do seem to be shifting in some way.
I'd agree with that. And I think what it's done is, coming back to the narrative, it stopped it being, you either drank or you didn't drink. And part of what, when I was teaching, health professionals, there's a case of, there's the people over there who are the non-drinkers, who are a bit weird. Then there's the people over there who are the alcoholics, who are them. And then there's us in the middle. Mm-hmm. And I think we've had this awful sort of way of categorizing people, that you've got people at either end who are different. And that everything that all of the 80% of the people in this country who drink alcohol was somewhere on a spectrum. And I think what it's enabled us to do is to bring in the celebration of sobriety as something that you might make as an active lifestyle choice, not just something that's foisted upon you because you really can't take alcohol anymore. And I think that's part of changing the narrative, as you were saying, is it's becoming it's just becoming more diverse. And therefore people can have a full range of relationships with not just alcohol, but also, I think, it fits more broadly into the lifestyle kind of medicine perspective. And if we are genuinely moving towards health rather than illness, the whole thing around physical activity, what we eat, social cohesion and connectiveness, all of those things that, the evidence is increasingly is where we need to be.
Yeah, I do think, though, that the economics are important, and there's a really consistent finding over, long periods, that during times of recession, when disposable incomes are less, alcohol harm rates fall. Okay, so you can broadly say there are two things that happen. People get stressed, they get worried, they might drink more, but also got to tighten our belts, can't afford everything, need to reduce. And the second of those effects appears to be more powerful than the first, historically. And disposable incomes, particularly for young people, have fallen a lot since the credit crunch and with austerity. So I wouldn't be so sanguine that we have, if you like, a kind of cohort effect that's going to stay where it is. I still think that there could be economic changes. The big increase in Scottish liver deaths was during the New Labour years, when incomes were rising and it was all good times. So actually that's when our deaths really went up. So I wouldn't, as I say, be so confident that there's, as I say, a cohort effect that's going to last forever. I think there are period effects that can kick in. I think, so of course we don't want to rely on economic recession to keep alcohol harms in check. We need to be doing other things, but it's subject to change. And I don't think we should be too kind of complacent about the current young people's situation. I certainly hope it lasts, but I think we also need to put in some things and some guardrails to make sure it's maintained.
I suppose this is an early government, and like you said, if they are really serious about moving to prevention, at some point they're going to have to think seriously about alcohol. Mm-hmm. They are new. Hopefully they feel that they're going to be able to take some bold steps. But there's a role for everyone else then to keep the pressure on, mm-hmm. to have a narrative which brings about the right actions. Mm-hmm. And coming back to that policy window when it opens, because you don't know when it's going to open, there's got to be a good network of people to be able to respond, to be able to support civil servants who do that. We've seen that with MUP, we've seen it with the duty. the duty's relatively new now based on strength. There's opportunities there.
And just to say something on that, so a piece of work that we haven't published yet, we have looked at the proportion of alcohol sales that are occurring below 3.5% ABV. So that's for the products that are being charged a lower rate of tax. And we know this is of interest to the government because they've sort of asked us to say, well, what we would like to happen with this policy is to encourage industry to make lower strength drinks. What we've seen is before those duty reforms came in, around 5% of beer sales were below 3.5% ABV. It's now up to 20%, and it happened almost immediately.
So, if that's in terms of sales, that's acceptable to the drinkers, if you know what I mean. So I think there's things like that, and it would be nice to see if they applied the duty escalator again. So it went up 2% above inflation every year.
Yeah. The flip side of that is we're not seeing the same thing at the higher strength band. So we're not seeing the stronger lagers being moved below that level as well, partly because of the way the policy was structured. It wasn't quite the same thing. One of the things we've written about a little bit is that we see this big decline in youth drinking. It does seem to be translating into young adults as well. The most recent health survey for England data came out last week and seems to support that. But at the same time, we've got the heavy drinking generations, the kind of binge Britain generation of the late 90s and early 2000s, my generation basically. And they're moving through the life course, and they're moving to the point where liver disease starts to hit, and increasingly towards when heart disease, cancer start to hit. So you've kind of got these two different things going on in the population at the same point, and the phrase I've tended to use is things are probably going to get worse before they get better.
We are a decade or two before seeing any cohort effect coming through to liver disease and other serious organ-specific complications from alcohol. Absolutely. And if you look at the health survey of England and patterns of drinking, there's marked binge drinking behaviour in men and women in the sort of noughties that has tailed off. But we're seeing the effects of that now, as you point out. That's borne out through some of the alcohol data.
And I think the other risk that we've got, because I want to be positive too, and actually, you know, I think the recovery community are the most amazing community. And if you spend time with them, it's the one thing that gives me most joy in my life, because they're the people who've been and examined every single part of themselves to be in that position of recovery. And like you say, the things that you see people succeeding on is really amazing. Let's keep that. Let's make sure that that is really visible. But at the same time, the industry are saying, look at this drop in youth drinking. That's because of something we're doing. That's because of the education we're providing. Just keep doing this and everything will be okay. And that's not true either. And, you know, there is something around how we don't have so much optimism that we lose sight of, you know, the things that are really going to make the big difference.
Yeah, there's always this risk that things getting better actually makes our job harder to point out, actually, there are still really big problems here.
And those young people who are drinking are still drinking to excess. They're still drinking in a way that's incredibly harmful. You know, we know that our most disadvantaged communities, the alcohol paradox, are most likely to experience the greatest level of harm. We are still seeing that. You know, so there is something around, and there is a well-being movement going on, but actually it isn't across the board. But I genuinely think we can't tackle the issue of tobacco harm, alcohol harm, weight, particularly, unless we tackle all of them. Because if you think about the calories in alcohol, we haven't talked at all about the calories in alcohol, the impact that that has on healthy weight, but the impact that drinking then has on what people eat, and the fact that people then pick up a cigarette, and, you know, all of those things, if we're thinking about it from that sort of individual perspective, need to be tackled together. But I do like the shift from people to product and promotion, you know, so that we can start to have a different conversation.
Absolutely. And I think one of the other areas is that in communities such as mine, which make up a percentage of the UK's population, it doesn't exist. So as much as we're saying, you know, blame the product, blame the people, it doesn't. Within communities like mine, we very much are in denial that it even exists. Our efforts aren't in trying to help people not have alcohol. Our efforts are in trying to hide the fact that it even happens, you know, to men. And I think that should, you know, that can't be forgotten as well.
If we just finish by a little bit of a talk about what different groups can contribute to helping change happen. And one of the things that I often noticed when I was working on minimum unit pricing earlier in my career, particularly, was that clinicians often play a really important role, because they kind of have a voice both as frontline workers who see the really sharp end of this, but also they're kind of authoritative voices of a medical community, and they're often researchers as well.
Actually, a usefulness about some of the medical professionals, like them or love or loathe them, is that actually we do hang around, often in the same institutions, often for decades. And consequently, actually, it does mean that you can actually see change through, you can, upscale things, you can be an institutional memory, and you can stop things just floating off the minute that actually it's expedient for somebody to change it. So I think there is an advantage in that. I think also, though, there is that sense of bringing frontline stories into the agenda. And for me, what I do clinically, I think a lot of the time is hold hope for some of the patients that I see who've completely lost it themselves, and in some ways around kind of developing a strategy, or at least pushing for a strategy or a framework. I think there is still that balance of holding a hope whilst you're still aware of the fact that it feels at times challenging.
I think, yes, medics have definitely got a role in terms of championing this agenda and being heard. I've often said from the positions I've held when something was happening or we had something we wanted to say, have we got a medic who can say that? Because they're trusted, politicians can't easily silence them. They need to put their heads above the parapet, I think, far more often. I think that also applies to public health people too. The public health world at the moment is very quiet. I don't hear anything.
And a lot of public health work is done at the local authority level. I mean, do you feel like local public health people could be doing more?
Yeah, I mean, it's interesting because during the pandemic, the people who our local community wanted to hear from and trusted were those trusted leaders within their community, whoever they are. So I think we need to make sure that we're not losing sight of it needing to be a medic in a hospital, but actually who are the people that are most important to that community. And I think that's important. I do think that there is a fear at the moment around being too vocal on some things, partly because lots of us have got local elections coming up, and, what are people allowed to say? How far are people allowed to go? And in different places, there's different limitations on what can and can't be said at a local level, which creates challenges, or at least people feel that fear. So I think that there is that as well. And there is also the bit around not always being heard, so actually making sure that you have some of those new voices. I do think hearing from the recovery community themselves is probably the most powerful thing. When I was talking about a licensing hearing that I attended a while ago in Gateshead, somebody from the recovery community came and talked about the impact of having to walk past there on their way to their recovery service. And actually, I'm sure that was much more powerful than hearing me talk about stats and data and the other things. So I think there's something about the way we tell the story and who's trusted by the community that we're trying to speak to.
Yeah, I read a really nice piece by Alex Stevens on drug policy recently, where he talked about that those stories are really important for getting the issue up the agenda, getting policies in place. But then you need the evidence, because at some point, parliamentary committees are going to look at this and they're going to scrutinise it, and that's when you also need the evidence as well. So we need the stories and the evidence. But in terms of stories, Auni, I mean, we can't do research now. Essentially, if you're doing a piece of research, you have to have patient and public involvement, and for us that often means people with lived experience of alcohol use disorders, or whether themselves or their family members or whichever. But that's not always clear that happens in policy making. Do you think that lived experience could play a bigger role in actual policy debate as opposed to research and so on?
Oh, absolutely. I think it, much like Alice said, it brings it to life. An example of that is when, not taking it away, but just in my experience, during my bachelor's degree, it was biomedical science, and I was learning about Crohn's disease. I learned about all the chemistry, the biology behind it. And then I met someone with Crohn's disease, and they told me exactly what it was like to live with Crohn's disease. And it brought it to life. I was no longer just reading from a textbook, knowing theory. I gained an insight into what that actually means, and the same applies with alcohol and lived experience.
Great. Okay. Last word from Peter then.
Yeah, I do think with lived experience, there need to be frameworks for lived experience people to participate. So we're Royal College of Physicians, Royal Free Hospital, University of Southampton, University of Sheffield, Gateshead local authority, we're all coming from institutions, and Darren McGarvey, Scottish writer, has written well about this, that lived experience people can't just be out there on their own. They need to be coming from somewhere. They need to be coming from a community. It doesn't need to be an institution or some sort of body. Maybe it does. And I think we need to be careful not to exploit people. And they need to be coming from a not necessarily a safe place, because there is risk putting yourself out there. That's why it's important. But I think that we need to be conscious that people are, as I say, feeling part of a community and representing a community, and not just out there on their own, because that can be a very vulnerable position.
Great. Thank you, Peter. Okay, so that's the end of our session on the positive sides of this debate. Hopefully there's something in there that we feel actually there may be shards of light here. Okay, so we're going to finish off today then just by going around the table and having a look at what people have learned today. So maybe if we start with you, Julia, and I'm going to ask the same question to everyone, but what's the biggest thing you've learned today that either you didn't know or that you hadn't really thought about before?
I think it's just been a very helpful reiteration, the quote that Peter said earlier on, which was about, the trouble with the truth, it's the same old truth, and that we shouldn't get diverted into doing bright, shiny things just because they're bright and shiny. Innovate where there's a really good reason to innovate, but try and get people to do well the things that we know there's an evidence for doing.
Great. Clive?
I think for me, it's sort of obvious, but it really struck home, is how this agenda touches so many people and so many professionals and public. It's really important that we understand different people's perspectives. And actually, we're all trying to head in the same direction. And I think what's been nice about this as well is the fact that there's been no tribalism. It hasn't been public health and treatment and all that. Actually, we can all head in the same direction.
Alice?
Yeah, so I think probably what I'm taking from it is I feel kind of revitalised that we are doing the right things and saying the right things. And from that final session, I was thinking the bit of hope that I take from this is that we almost had minimum unit price in the 10-year plan. And whilst that felt very disappointing that we didn't have it, I think the fact that it was almost in there shows us that we've made some progress in persuading the people that we need to persuade that this is a really important issue. And it was also something that Peter said to me this morning, which was around sometimes the wind is blowing in the wrong direction, but we need to be the signpost that shows people the right way to go. And so it's almost reaffirming the fact that we just need to continue doing that and hope that the people who listened for the 10-year plan will grow and that therefore we'll get something in next time.
I think for me it was just gaining an understanding of how the role the alcohol industry has to play in terms of policy and government, which is something I wasn't actually aware of. So it's been really, it's been an eye-opener to learn about that, because obviously I'm working on the ground and usually with people or organisations, but more at a training sort of level or representing, a brown woman coming from a community where it's very taboo. But it's given me an insight into how much of a battle I guess it's been and why it's taking so long in terms of alcohol.
Great. Peter?
Yeah, I guess it's actually the mix between, if you like, the seen impact and the unseen impact. We have the seen impact from our health stats, our health data, particularly liver disease and all the stuff that you and I and others spend so much time thinking about, and that's very important. But also there's the unseen impacts that Oni talked about, hidden in the community. Nobody talks about it, it's not there. And the unseen impacts on families and so on that we don't really measure very well. So I think it's trying to keep in mind that the seen stuff is just, if you like, a barometer for a lot of the unseen stuff, and just trying to keep that in mind, I think.
Susanna?
Well, it was a reminder for me to be ready when opportunities present and to seize the moment. And also in the meantime, to make sure that we take note of and link with, where it's useful, with other public health issues where large corporates are the causes of so much harm.
Gautam.
The one thing that I'd not heard before that I learned from today was the astounding claim that the alcohol industry refused to accept causality for alcohol in living, which I'd never heard before. But more positively, turning on a positive note, I think the fact that we're here from broadly different backgrounds and here trying to tackle the same, albeit growing problem in different ways was very cheering to me. And yeah, that last session in particular left me with some green shoots to go away and think about.
Well, I'm glad we did find some shards of light. I mean, for me, again, it was similar to Peter, as someone who spends most of their day looking at population survey data, hearing from Auni about some of the hidden problems, the way alcohol problems operate differently in different communities was really insightful and something I'd not had much opportunity to explore before. Okay, so I think that brings us to the end of this roundtable. I'm hopeful everyone has found some things amongst what they talked about as kind of new, and hopefully everyone has a safe trip home. Thank you, everyone.